right. Hello, everyone, and thank you for making it to our really special session today, where we're going to be talking about some really deadly viruses, as well as what we need to do to fortify our defenses against these. And with that, we have some incredible speakers. Sorry, I'm just advancing. We also offer CME, and to claim your CME, please make sure you take the survey towards the end. It's only applicable for those who are doing the live, attending this webinar live. There's also CNE available. None of our speakers today have any financial disclosures. And in addition, we also have Dr. Matt Leslie, who will be a panelist and help answer some of our questions from our attendees. So what do we really want to achieve today? We really want to make sure that we raise your awareness of the emerging threats that are really, in some ways attacking us in Illinois, when the focus on viral hemorrhagic fevers. And we want you to understand how to effectively prevent the spread of these by early diagnosis and exposure management. And finally, we're going to really end with some real world lessons from health systems like Lurie Children's that are actually doing this and functioning as special pathogen treatment centers, and what can we all understand about how our roles as clinicians and public health professionals interface with this. So we're going to start us off with Dr. Austin. She is our amazing public health veterinarian and deputy state epidemiologist, and she will really go into the hows and whys of these emerging threats. I'm going to go into clinical considerations for those who haven't been to a prior PHACT series. I'm Arti Barnes, the Chief Medical Officer at IDPH and an infectious disease physician by background. Then Dr. Gels, who is the division chief of our lab services, will really go into what clinicians need to know about appropriate sampling and testing for these deadly pathogens. And finally, Dr. Koscielek, who is the Vice President of System Preparedness and Prevention and Response, will really go into the real world, again, preparedness and understanding of what it takes to set up high-level isolation units, as well as special pathogen treatment functions within a health system. So with that, I'm going to open it up to Dr. Austin. Please take it away, Dr. Austin.
Yeah, thanks everybody for attending today. And I'm going to start us off with a quick overview of how these new and unusual infectious diseases can develop or get into the United States. And as a veterinarian, I wanted to point out that about 75% of the new diseases are actually zoonotic or transmissible between people and animals. So there are several ways an infectious disease can make it into the U.S. One is that a new disease can actually develop within the U.S. Secondly,
Dr.
the disease...
Austin, are you advancing your slides, or are you still on the first slide? Do you want me to advance for you if needed?
Oh, I did. On my screen, it looks like I have.
Oh, I think we're not seeing any advancement. I can try.
Okay.
All right.
Let me know when you're...
All right. Yep.
Okay. So there are several ways they can make it in. The disease can be imported from another country, and this importation can be in an infected animal if it's a zoonotic disease, or it could be from an infected human traveler. And one other possibility is infectious agents are present in laboratories in the US, and I'll mention a few examples of each of these. Next. The best example of a disease developing within the US right now is H5N1. High-path avian influenza, or H5N1, began in wild birds and poultry in the US, and then dairy cattle began to be affected. And then people working with the dairy cattle became infected. So a new disease can certainly develop within our country. Veterinarians in Texas were puzzled by the disease in the initial herds. They ended up comparing notes, and after discussions with each other, they couldn't figure out what was going on. One vet mentioned that cats were dying at the dairy farms. You typically don't think of influenza with dairy cows, but when they heard that the cats were dying, the vet said, wow, we should start testing for influenza, and that is how the disease was identified through an astute veterinarian. And today I just have to mention we've had several people call-ins today about people who are trying to save sick geese, and they put them in their car and they have no PPE, and they just take them to a rehab center or a veterinarian, and they then are exposed to H5N1, because oftentimes these bird die-offs are due to H5N1. Next slide. So I wanted to mention a few diseases that have been brought in through infected animals. In case you didn't know it, people in the U.S. love exotic pets. So we had a sole virus outbreak appear in the U.S. when imported pet rats who carried the virus and gave it to their owner. The first person was in Wisconsin. An astute clinician in Wisconsin picked up on the connection between the pet rats and the owner's illness. And then I got a call from the Wisconsin Department of Health saying these rats are being sold out of Illinois. So we had to do a lot of work with the ratteries, testing them and making sure they had no more sold virus. In the first situation where monkeypox was seen in the US, there were imported giant rodents from Africa, which again were being sold as pets. They were housed next to prairie dogs that were also being sold as pets, and the prairie dogs were very susceptible to monkeypox. And the first human case was seen in Wisconsin with another astute clinician. And then I got a call from the Wisconsin Department of Health saying, hey, these prairie dogs are being sold out of the Chicago area. So we had to track that down. And finally, we had imported rescue dogs from Azerbaijan who were brought in through O'Hare. One was driven right to Pennsylvania and ended up developing the canine strain of rabies, which is not present in the US. Luckily, there were no humans infected, the other dogs were not infected, but all persons receiving the dogs had to be tracked down, and the dogs had titers drawn. And it turns out that the veterinarian in Azerbaijan was giving only half a dose of rabies vaccine to save money. So anytime you want to focus on horses, you have to remember that sometimes there are zebras out there. Next slide. Some persons who come into the U.S. from overseas may also be carrying infectious diseases. International travelers with a visible illness should be picked up through airport screening. However, people can take fever reducers if they're not feeling well or be reluctant to mention details of their health. So you can't assume that every person will be picked up at the airport. And when a country is experiencing a viral hemorrhagic fever outbreak, CDC will have these passengers funneled to a few chosen U.S. airports where CDC employees will do enhanced screening in case someone coming in has signs of a viral hemorrhagic fever. It's so important that healthcare providers ask the travel question with anyone who has what looks like an infectious disease and be very specific. For instance, Africa is a huge continent, and just knowing someone went to Africa is not as good as knowing which country in Africa they went to and being aware of what the current situations are in Africa as far as infectious disease. We also did have an incoming traveler from Saudi Arabia who had MERS, and as soon as they got out of the airport, they traveled on a bus and then visited a number of individuals until they finally sought health care. And luckily, we had no transmission within the US. Now, the next slide. One of the things that most people are extremely wary about, and obviously the most fear is people have, is for viral hemorrhagic fevers. And 3 of these viruses are Ebola, Marburg, and Lassa fever. They can be causing outbreaks at any time overseas. So you have to really know where did the person come from and what kinds of things are going on in that country. Next slide. An example of a viral hemorrhagic fever response is the Marburg outbreak that started in Rwanda in late September of this year. At the beginning, most of the people affected were healthcare workers, especially those working in ICUs. US-based doctors do go to Rwanda to assist with healthcare activities there. Exit screening for passengers leaving from Rwanda began. So when they were leaving the country to get on a plane, they were screened. And then there were funneling of these passengers in the US began in October to 3 airports, ORD, JFK, and Dulles International. ORD is the only city with a receiving airport without a funded regional special pathogen treatment center within the city as far as adults. So this is disturbing to us, and we're working on trying to make sure federal authorities understand that. So along with the funneling, anyone who answered yes to a high-risk exposure was monitored daily by public health authorities. If symptoms were suggestive of Marburg, they would have been directed to appropriate care. There were no reported cases of Marburg in the U.S. resulting from this outbreak, and the funneling has ceased as the outbreak is over overseas. Next slide. We also had a recent situation with Lassa fever. In the US, there have been 8 travel-related Lassa fever, which is a viral hemorrhagic fever. The last imported case was in 2015 until on October 28, 2024, a fatal case of Lassa fever was reported from Iowa after the person had a recent trip to West Africa. Malaria was initially suspected, but there were multiple negative malaria tests on the individual, and the person ended up testing positive for Lassa fever. After 3 hospital visits and EMS transports, over 100 healthcare workers were considered to have high-risk exposure to this patient. Over 30 of them were Illinois healthcare workers who worked in Iowa. All exposed high-risk individuals were monitored daily by public health. Anyone who had any symptoms of illness was immediately taken to the appropriate healthcare facility. No one tested positive. In the 21-day monitoring period, we all had a big celebration when that was over with, and there were no secondary cases reported. And finally, next slide is one other example of when we can have trouble with infectious agents is through research laboratories. One concerning example I think probably everybody has heard in the news is in Australia, which has been in the news with 323 vials of infectious agents, including Hendra, Lissa, and hantavirus missing from the lab. Let's talk about some Illinois-specific situations. We had an incident in Illinois where a grad student at a university was working on a non-pathogenic organism for her project. Someone who was helping her pulled a vial out of a freezer. She began using this in her work, and she ended up getting cowpox. Frost had covered the label in the freezer, and the wrong vial was removed. So something very simple can result in transmission of an agent. Another situation involved a person working in an Illinois lab with an attenuated strain of plague, but unfortunately, he had an underlying condition he was unaware of, and he ended up getting plague and dying. And finally, there was a research lab that was supposed to be getting blood samples from an African country that were negative for viral hemorrhagic fevers, but one specimen arrived that was positive for Ebola. They were working to develop a new test, which was a good thing to do, but then they had to have their employees make sure their employees had not been exposed and there were no cases in those lab workers. So that is good news. So always, next slide, always remember, you want to focus on the horses as far as infectious diseases, but there are always zebras out there that you need to keep in the back of your mind once you've ruled out those horses. Dr. Barnes is up next, and she'll get going shortly.
Thank you, Dr. Austin. And so let's, think about some of the things Dr. Austin has mentioned to us. And I'm going to highlight from the least supposedly deadly virus to the most that we're going to discuss today, just highlighting 4 of them. There are several more out there. I don't know if people have heard about the Oropouche virus. So this is something that really came into the news the last year. It's been around, especially in the Amazon, but hadn't really hit our radar here on the continental US till last year when it was a huge outbreak in Brazil. Till date, between Brazil, Colombia, and even, in Cuba, we've seen about 9,000 cases. And in the US, we have now, as of 2 days ago, 101 cases. Two of them became neuroinvasive, and there are 6 states. Illinois is not one of them, but 6 states, mostly heavily in Florida and California, that are reporting cases. So this is something that I'd like to put on your radar, because this is why it matters. You think, well, we're not Florida, right? I mean, we don't see those cases, but thanks to the Chicago Department of Public Health, who use AI services to try to predict importation risk, especially given O'Hare, you can actually try to estimate how many people are coming in from different airports into O'Hare, into Chicago, what are the risk of acquisition, and it turns out our risk is not negligible. But then the thought is, okay, so we might get a little bit of Oropouche, but what does it really matter, right? Can it really spread locally? And there are 2 known vectors that we're currently aware of. And I think this is the challenge, that we're not fully aware of all the different sort of vector implications from Oropouche. One of them, the biting midge, the culicoides, we don't have in Illinois. It's in the neighboring states. But unfortunately, the common house mosquito, Culis fasciitis, that is everywhere in the US. So there is a theoretical risk. And so what is CDC really asking us to do is think about it. Think about, if it starts spreading locally, do we need to think about vector control strategies? Do we need to think about more surveillance strategies, especially for biting midges? So that's from the public health surveillance end. But from a clinical end, the good news is that while most people will be symptomatic, very few will really develop severe disease. It's self-limited. Most of the people will resolve, but the presentation can be a little confusing. It's flu season, respiratory viral season. It mimics dengue, Zika, and chikungunya by symptoms, but it could be the flu: fever, chills, headache, myalgia, arthralgia, body aches and pains. Some of the unique symptoms that you will identify with more with Oropouche than others, than say your local flu, is retroorbital pain and photophobia, neuro symptoms, GI symptoms. You can get that with the flu, but vomiting, diarrhea, and a rash. We don't usually see our rash with our seasonal flu. However, you can see conjunctival injection with Oropouche. Now, there is the dairy strain, the dairy version of our bird flu strain that does also present with conjunctivitis. But think about it, if someone has an appropriate travel history and starts developing these symptoms, keep your threshold low for whether this person really warrants testing or not. And some lab findings that are unique, again, relative to, say, seasonal flu, would be lymphopenia, low blood count, or your white blood cells, and leukopenia. So in rare situations, this can transform into a hemorrhagic version. Now, this is not considered a classic viral hemorrhagic fever, so that's important to know, but it has the ability to to have hemorrhagic transformation. But the neuroinvasive piece, the meningitis, meningoencephalitis, that is something that's important to just be aware of, and you're going to have to test using your CSF. You're going to see pleocytosis and elevated CSF protein. One vulnerable population that's important to know about, especially if you care for pregnant people, or if you are one yourself and planning on traveling to a place that may have a lot of Oropouche, is just the risk to your fetus. And there have been, unfortunately, pretty significant negative outcomes, both stillbirth, birth defects that are noticed. So CDC has issued a level 2 travel health notice for those who are pregnant people. And just, it's very hard in some areas, but healthcare professionals, we love our medical missions and we love traveling, even when we're pregnant. So just be aware of the risk. Now, unfortunately, no vaccine, no specific treatment. It's mostly supportive. Any viral hemorrhagic fever or a condition like Oropouche, and then I'm going to talk about dengue too, that can have hemorrhagic transformation, you really want to avoid NSAIDs, ideally, to just avoid the risk, lower the risk of hemorrhage. Pay attention to travel notices. Dr. Austin mentioned that. It's really important. And if you are confused about how to really think through CDC travel notices, at the bottom of the link, and we'll send you these live links too, is really a tool. You just plug in your patients or your own information, and it'll really it makes it easy for you, let you know what you really need to be cautious about, what prophylactics you need to be considering. So pay attention to the travel notice, pay attention to what CDC puts out, especially when emerging pathogens occur. There'll be new guidance often. This one, they have a guidance for clinical management of pregnant people, and they're flagging both the local health departments and providers on how to really notify CDC of this condition. So just your role as clinicians to just flag your local health department if you see or suspect, for example, Oropouche or any of these conditions. So spoke about Oropouche. What's worse than Oropouche? Dengue. And you said, why dengue? Well, we spoke about a theoretical risk of local transmission. Unfortunately, that has started happening in the US right now. There is local transmission in dengue. You can see Florida, even Puerto Rico, really lighting up for that. So local transmission starting to happen. Why is that concerning? Because the mosquito that transmits dengue, the AD strains, they're in Illinois too. So we shouldn't, again, think ourselves so remote and removed that this could not really occur here. Thankfully, yes, it's winter, but our winters are getting milder and our summers are getting warmer, and mosquitoes love that. So, and again, more extreme precipitations. Those who grew up in a tropical country know that mosquitoes love that too. So the second challenge is that there's really no further vaccine production. So Dengvax, yes, Sanofi Patch has stopped producing that vaccine anymore. And it's really recommended to prevent dengue in children who are 9 to 16 years old, who've already previously had dengue virus, because they could get severe dengue the next about, and they live in areas where dengue is common. So we're talking about children in Puerto Rico, and this is important. Dengue can come severe in a few hours with uncontrolled bleeding, shock, and organ failure. Again, no treatment, supportive care. If you work in the hospital, again, prophylactic platelet transfusion, steroids haven't really been proven to help. So let's talk about the more classic viral hemorrhagic fevers. Dr. Oss mentioned Lassa. Lassa came very close to being in Illinois. Unfortunately, again, it really is one that we have to think about what resources can we galvanize for this. Now, most viral hemorrhagic fevers go through like a dry phase, which looks like the flu: fever, headache, myalgia, sore throat, fairly indistinguishable. But thankfully, the dry phase is not as contagious as when you move to the wet phase. And this applies to Lassa. This more specifically, again, applies to all the other hemorrhagic fevers too. So the wet phase is really when you're with diarrhea, vomiting, and even bleeding. And that's when you would be at higher risk for coming into contact with these fluids. It's also the amount of virus in the blood is going up. The viremia levels are higher, and so there's a higher risk of transmission. Now, one thing that's a little unique to Lassa specifically is during the recovery phase, you might actually get hearing loss. Of course, by then, it's not like we want to diagnose people that far into their course. The sooner we identify, the sooner we can triage, the better. The good news with Lassa, 80% will recover. But of those who don't, the ones who develop severe illness, the ones who end up in the hospital, the case fatality rate is pretty high. Transmission is not as high as Ebola or Marburg. And thankfully, thanks to some phenomenal efforts to the Iowa Department of Health, there was no secondary transmission in all the healthcare workers that were exposed to this case, often without adequate PPE. Just one thing to note, it is deadly in pregnancy, this time not just to the fetus, but it can, even the maternal outcomes, even the rate of maternal loss and death is high with Lassa during pregnancy. So finally, we're going to talk about, just remind you of one of the most concerning hemorrhagic fevers. And again, not considered necessarily as deadly as Ebola that we think about, but something to really pay attention to, considering the recent outbreak in Rwanda and the funneling through O'Hare of all the people from travelers from Rwanda. Most incubation periods for viral hemorrhagic fever is about 21 days. That means 3 weeks of monitoring. And as we mentioned, you go from dry to wet, but you're not contagious with these till you develop symptoms. The good news with Marburg is that we're a little further ahead of the game. There's one investigative monoclonal antibody that has actually been used for treatment in Rwanda, and an investigative vaccine that has actually been deployed as post-exposure prophylaxis. And we're waiting to see truly some real-world efficacy results from those. So what does it mean for healthcare workers to get exposed? And this is something all healthcare workers need to pay attention to. We're the ones who have the highest risk of exposure, along with the household contacts of these patients. Any skin or mucosal membrane contact with body fluids. Now, you're right, it won't just permeate through your skin, but we often have microabrasions, small cuts in our skin we may not be aware of. Household contacts are de facto considered high risk because it's hard to quantify the risk. Any breach in PPE, especially when you're delivering healthcare or if you're handling a dead body without the appropriate PPE, is considered high risk. And that's because you're most infectious around the time, unfortunately, of death because of the amount of virus in the body. So the Denver Regional Special Pathogen Treatment Center came up with this great article, I think just a couple of months ago. Take a look at it. It compares viral hemorrhagic fevers, dengue, yellow fever, Marburg, Ebola, Lassa, South American hemorrhagic fever, and of course, Crimean Congo and Hanta. And it tells you, we need to think about One Health, how our animal and human and vector interface is starting to really get more complicated. And what can we do? So PrEP is pre-exposure prophylaxis, often vaccines. Medical countermeasures, MCM, refers to treatment and post-exposure prophylaxis. CP is convalescent plasma that you can see has been used in cases. And H2H is human-to-human transmission. So they're trying to give people an understanding how easily transmissible. Dengue is not, thankfully, but the other viral hemorrhagic fevers are. And CFR is case fatality rate. And you can see it goes from being, not as concerning with dengue to really like over 50% with Marburg, and quite variable with Lassa and the Crimean Congo and hantavirus syndromes. So this is another algorithm I just want to point clinicians to. This algorithm really has you think, is this a person, how contagious are they, and how do we think through monitoring? So the green is not so bad, they're dry, and red is wet. And if someone is at risk, a suspect case was present in an outbreak area, in the outbreak country, they really have mild, dry symptoms, you could do a virtual assessment model, potentially even home visits, virtual video visits with infectious disease, hospitalists, decide if this patient is stable. If they're stable, can they stay in daily video monitoring at home? And are they appropriate for that, even based on their home situation? And then what else do they need? They definitely need sample collection. If your index of suspicion is high, you need to make them aware of what are the red flags they need to pay attention to, and that they have the capacity for daily video home health monitoring. And Dr. Koshelek is going to go into some of the aspects of their teletriage work for this through Lurie. Now, if someone is critically ill, has wet symptoms, you need to get them to what's called a high-level isolation unit. And if you're not able to transfer them to a special pathogen treatment center, the question is, how do you set this up for yourself? And there are several activation checklists I'll go into in a second. So the National Emerging Special Pathogen Training Centers, NATEC, has actually a list, a preparedness checklist for frontline healthcare facilities. There's a live link in there that I will share and people can review. So just to reiterate, that real transmission risk really occurs from body fluid contact, and that's what has to be minimized. The contagiousness often does not start till you develop symptoms, but can last and can be detected. We think it's not super contagious, but we cannot rule it out for, say, something like Lassa for weeks, even after recovery. There's thankfully no airborne spread between humans, specifically for something like Lassa. And there are post-exposure prophylactics you could consider for your exposed contacts, which is either ribavirin for Lassa, not considered great from an efficacy or tolerability standpoint. And of course, there's the Marburg vaccine that we're a little more optimistic about. So what do we need to think about from a preparedness standpoint? So the good news is there are 37 labs, laboratories across the US that can test it, including thanks to Dr. Gels's work at IDPH in Illinois and getting the right kind of testing reagents. We helped Iowa help with their testing because they needed some additional support for that. Unfortunately, while we have good testing capacity, we don't have great treatment capacity. There are 13 regional special pathogen treatment centers across the EUS. Each one has only a capacity of 1 or 2 beds that they can see these patients at. There are none in Illinois. The closest one is Grand Rapids, Michigan, or Minneapolis. And sending patients who are sick to those 2 centers is not always tenable. We have 1 or 2, not regional, but just local special pathogen treatment centers, which don't often have the sustained resources to maintain it, like the what we call the respect sites. And both of those are in Chicago at this point in time. And so I think this poses a significant challenge to triage and clinical transfer. So if as a clinician, you are faced with being in a hospital with a patient who has special pathogen, with a special pathogen, and you need additional resources, there is a process in place for hospitals to request these additional resources based on the disaster. So you activate your disaster response resource request. And in orange, again, it's the steps that hospitals think about how to request it. And they request it of their local health department, their local EMA, emergency management agency, or their local their assigned regional healthcare coordination center, RHCC. And in blue is what the local government will do, and green is what the state government will do. So I think just wanting to make clinicians aware that these are scenarios to start thinking through. And with that, I'm going to open it up to Dr. Gels.
Good afternoon. So I'm going to talk a little bit about individual specimen submission. Share my screen real quick. All right, hopefully everybody can see my screen. Talk about specimen submission, testing and safety. And then we're going to go in a little bit of disinfection practices at the end and provide some resources for individuals to actually utilize to determine what type of best disinfectants based upon the type of pathogen that you're working with or within your laboratory have identified to actually use to properly sanitize and disinfect your workspaces. So what I'm going to talk about first, piggybacking off of Dr. Barnes's talk, is Oropouche. So we cannot test Oropouche directly at IDPH. That is a CDC test only. But if there is a case of Oropouche that is identified that requires testing, the minimum specimen collection is 0.5 mils of serum or 1 mil of cerebrospinal fluid. And there's going to have to be several samples actually taking for that within the first 3 to 10 days of symptom onset or the acute phase, and then again following on 2 to 3 weeks after acute sample collection. They do not allow whole blood to be collected. So when those specimens are collected and routed to the IDPH laboratory for us to submit down to CDC for further follow-on testing, we are not allowed to utilize whole blood. So keep that in mind. It's kind of unique to Oropouche. Some safety considerations. There has been laboratory exposures that have occurred with Oropouche in the past. These have typically been as a result of individuals that had improper PPE being used, utilizing samples underneath the hood, having broken gloves and then cuts on their fingers, and then introduction of that into their body. So all manipulations need to be performed underneath certified biological safety cabinets. And because it is not transmissible from person to person under with direct contact, standard PPE precautions should be used when dealing with infected patients and samples. When those samples are actually transferred to the laboratory, they have to be kept at refrigerated temperatures or frozen, so 2 to 8 degrees Celsius or less than minus 20 degrees Celsius. Communicable disease requisition test form needs to be completed and then submitted along with the specimen. And because it is not a substantial disease for transmission, or which can cause multiple exposures upon exposure to that sample, it is considered a Category B substance. Again, testing is only performed at the CDC. They do utilize a couple of different technologies, including RT-PCR, but they still utilize serology, both IgM ELISA, which detects antibodies, and the microimmunoassay, which is IgM, and that detects the antigen in the serum. And then also to determine titers, they utilize plaque neutralization assays. So dengue, again, dengue fever, an arboviral disease, 3 to 5 mils of whole blood, that is purple top tube. We can test this at the IDPH state laboratories in Chicago and in Springfield. And this test for dengue is considered confirmatory. So we do not have to have any specimen shipped down to CDC for confirmatory testing or any follow-on testing. The testing for dengue is confirmatory, utilizing our global fever special pathogens panel at the IDPH labs in Springfield and Chicago. However, some safety considerations need to be considered with dengue. Again, there have been laboratory exposures that have occurred, and again, through to cutaneous exposures, improper glove doffing, and open wounds. And then also there has been some reported potential exposures due to mucosal exposure with specimens. So always utilize a biological safety cabinet and standard PPE precautions as well when dealing with samples and patients. Again, this is a 3 to 5 mil whole blood assay. So please send that at 2 to 8 degrees refrigerated. Again, a communicable disease test requisition form must be completed and submitted with the samples. And again, this is a category B shipment. For Ebola and Marburg, we can also test at both the IDPH Springfield and Chicago laboratories. However, these are considered preliminary tests. These are considered preliminary results. We do require that 2 independent collections of whole blood, 3 to 5 mils each, be submitted to the state laboratory. These need to be in plastic, sealed tubes. Do not open them. Do not utilize glass tubes. We want to maintain sample integrity and also prevent contamination or exposure of other individuals. So once they're filled, just make sure they're labeled and send them to us. Remember that safety considerations, filoviruses such as Ebola and Marburg can survive on dried surfaces for several hours. And if they are in bodily fluids, they can survive for several days at room temperature. All of these must be manipulations must be performed under a Class 2 BSC. So essentially BSL-3 practices or BSL-2 enhanced for patients, and enhanced PPE precautions when dealing with the infected patients and samples. Again, this is a whole blood EDTA collection, just like with Marburg. We're asking again for 2 of these samples. They are to be refrigerated. Again, a communicable disease test requisition form needs to be completed, but Ebola and Marburg are considered category A, even if it's suspected. So category A shipping practices, triple container shipping, and making sure that it's, even when it's couriered, it needs to be considered category A for shipping to the state labs. Like I said, using our global fever panel, we can provide a preliminary test result, but confirmatory testing of both negative and positive preliminary results must be confirmed at CDC. And that's why we're requesting that 2 collections of blood can be provided to the state lab, one where we manipulate, one that is unmolested, and then can go straight to CDC for for confirmatory testing. So again, just a testing overview snapshot. Keep this in your back pocket. I'm sure these slides will be disseminated. Oropouche, Cat B, goes straight to CDC for all testing as it passes through the IDPH lab. Dengue, Ebola, and Marburg are all tested at the IDPH laboratories using the global fever panel. Dengue is, whether positive or negative, results are considered confirmatory, and no further testing is required. However, for Ebola and Marburg, positive and negative results, preliminary results, must be sent to CDC for confirmatory testing. So now we're going to talk a little bit about the decontamination and disinfection practices. With viruses, typically viral morphology drives disinfection practices. Luckily, filoviruses, flaviviruses, and orthobunyae viruses are all enveloped viruses, which means that they're inherently less stable than non-enveloped or naked viruses like rotavirus and norovirus. So disruption of the viral envelope leads to inactivity of the virus. And there are several resources. One of the best resources that you can utilize is the EPA's website, which has approved disinfectants for emergent viral pathogens, such as tier 1 and tier 3 and tier 2 viruses or pathogens. And they go into substantial detail as to identifying what they consider or what is considered a tier 1, tier 2, and tier 3. So Marburg, Ebola virus, Mpox, SARS-CoV-2 are all tier 1. Those are all enveloped viruses. Rabbit hemorrhagic disease is considered a tier 3. Norovirus and rotavirus is tier 2. So tier ones are those viruses which can cause substantial disease in individuals as well. So when you get on the website, if you're looking at a tier one virus or an enveloped virus, you click on yes, and it automatically lists the approved disinfectants necessary for disinfecting and eliminating the activity of both viruses as well as bacteria. So I highly recommend to take a look at that and utilize this website for your own use within your facilities. There are also commercial products that they provide, as well as the company and the actual associated registration number, the catalog number, if you will, for those products, so that you can basically filter the type of disinfectant that you need or can purchase for utilizing these in both schools as well as nursing homes, individual households, those that can actually disrupt and destroy tier one viruses. So one of the most ubiquitous disinfecting agents is bleach. And I can't tell you how many times I have had calls on, what concentration of bleach or what type of bleach should I use? Well, it's not exactly a straightforward answer, because not all bleach is created equal. And not all bleach that's sold over the counter is is capable of disinfecting, and not all bleach is sold at the same concentration. So most household bleaches are between 5 to 10% sodium hypochlorite. Sodium hypochlorite is essentially bleach, and there are several different flavors of bleach. So there's these ones that are scented and splashless. Those are not disinfecting. Those are not capable of sanitizing and disinfecting surfaces, and they won't kill a lot of the tier one viruses or even the bacteria that they come in contact with. So the best thing you can do is to make sure that you utilize disinfecting bleach. So bleach is not all created equal. There, like I said, there's commercial bleaches that you buy, at Walmart or other vendors, are between 5 and 10% bleach, but not all of that bleach is available for disinfectant activity. So I put together a little chart and just kind of an example of the availability of bleach and understanding a little bit of how bleach kind of works. So essentially 96% of the bleach percentage listed on the bleach bottle is available for disinfectant activity. And what I mean by available, you have hypochlorous acid as well as chloride ions that are available that are not bound to diluents inside the bleach, and those are what's actually available for disrupting viral envelopes, for disrupting nucleic acids in both bacteria and viruses. So essentially, you need to be kind of careful with that percentage of bleach that you purchase or what's available, to make sure that your appropriate dilutions are created to achieve that roughly 10,000 parts per million for full bactericidal and virucidal activity in biological waste. So I'm talking about, biological waste in terms of soiled linen, soiled lab coats, destroying actual samples themselves. So essentially, 1 part per million is equal to 1 mil per milliliter, or excuse me, 1 milliliter per liter. And as a consequence, in the table below, because these ranges between 5 and 10% of bleach that's available commercially, there's different dilutions that are needed in order to achieve that 10,000 parts per million. So at 5% bleach, in order to achieve 10%, 10,000 parts per million, you need a 1 to 5 dilution. That is 100 mils of bleach and 400 mils of water. In contrast, if you use 10% bleach, you need essentially a 1 to 10 dilution, so half of that. But you have to take into account the actual percentage of bleach that you use, or whatever the disinfecting agent is, to pay attention to what the concentration is in order to make sure that you kill bacteria and inactivate all the viruses you come into contact with. And with that, that's all I have, and I'm going to turn it over to the next speaker. That would be Dr. Larry Casiola.
Yeah. Yes. Hi, let me get my slide shared here.
Larry, do you need me to share, or are you able to find it? Okay.
Here we go. Okay, so you should see them now. Do you you see my slides? I trust you can see them.
Yes, we can see that. Thank you.
Great. So my name is Larry Kosciolek. I'm a pediatric ID doctor at Lurie Children's and oversee our preparedness, prevention, and response efforts. I'm going to talk to you about our identify, isolate, and inform framework. This is a standard framework for special pathogen preparedness that really should be incorporated at all medical centers. And so I just want to talk briefly about our infrastructure, about how we prepare. It really is a team effort and requires a institutional investment and a lot of stakeholder input. And so at Lurie Children's, after COVID, we developed the Center for System Preparedness, Prevention, and Response to coordinate our experts in preparedness for really any hazard whatsoever. Realized our approach to infectious hazards tended to be different from non-infectious hazards, and we wanted to standardize that. This center oversees emergency management, infection prevention and control, our high consequence infectious diseases program, which I'm going to talk about today. I'll refer to that as HCID, and then our business continuity program. HCID really has overlap with both emergency management and in infection prevention and control. And I think this infrastructure with our center has really helped us prepare for high consequence infectious diseases. This takes a village. It's really an all hands on deck approach. We have an HCID committee. I'm not going to read all of these off individually, but what you can tell is that we need experts in all of our clinical operations, both the teams that will provide direct care to patients like the emergency department and the PICU, but also those like medical imaging and the laboratory that contribute to patient care. We also have many services involved in maintenance of our physical environment, both from a safety and cleanliness standpoint, and several areas that are responsible and very helpful for ensuring that we have appropriate education of all of our teams to be able to provide safe care to a child who may present to our medical center with a highly infectious and pathogenic infection. So when we talk about special pathogens and high consequence infectious diseases, what we need to be able to reinforce is the ability to identify a patient who may potentially have such an infection, how to isolate that patient should they have that infection or be suspected of having that infection. That's what we use to keep people safe, and how to inform the appropriate stakeholders of our concerns of a potentially life-threatening and high consequence pathogen. And that includes both internal stakeholders and external stakeholders like the Department of Health. So when it comes to identification, there's several things that we can do to improve the speed and accuracy at which we can identify a child with a potentially high consequence pathogen. And to do that, we need to do several things with our local stakeholders to ensure that they're knowledgeable and equipped with the appropriate tools to do this. And so first, it's very important that our institution and our key stakeholders have a really close connection and collaboration with public health officials and advisories that they submit when there's the presence of special pathogens in the community. It's also important that once we have that information, we use that information to proactively and reactively educate our frontline providers on the potential of encountering these infections. And finally, we can leverage our electronic medical record to make the identification process more timely, more accurate, and more effective. So when it comes to connecting with public health officials, there's several things that we do. First, I subscribe, and you all should subscribe to the Chicago Department of Public Health Health Alert Network. They provide both weekly reports of endemic infections like respiratory viruses and ad hoc reports about epidemiologically significant pathogens that present internationally or locally. The Chicago Department of Public Health and the Office of Emergency Management and Communications. Those groups converge in the Chicago Healthcare System Coalition for Preparedness and Response. And that group serves as a liaison between hospitals and providers and emergency management services in the city. When it comes to specific high consequence infections like viral hemorrhagic fevers like Ebola, there's been a long-standing partnership since October of 2014 during the Ebola outbreak in Western Africa, where the city of Chicago created a cross-hospital collaborative in conjunction with first responders and public health officials to have a dedicated Chicago Ebola response network to improve the speed and effectiveness for providing care to patients in the city with potentially with one of these potential infections. The state also is very effective and a really strong partner with us. The Illinois Department of Public Health oversees the Siren system, which is the state of Illinois rapid electronic notification system, which similar to the Health Alert Network, provides real-time updates to key stakeholders about the presence of some hazard in the environment. It's important also that providers subscribe to that. Lastly, from a national standpoint, the Centers for Disease Control and Prevention, they also have a health alert network which provides advisories. Oftentimes, the advisories that come from IDPH and CDPH first come from the CDC. Education is essential and is a strong part of what I do and my center does on a daily basis. We have several groups that we target. Locally, we have to ensure that our providers are equipped. And so this is an example of an email that goes out bi-weekly during respiratory season and then ad hoc throughout the year from the Center for System Preparedness, Prevention, and Response. It provides updates. And those updates are typically around epidemiology of both endemic and epidemic pathogens and key level clinical and public health points for providers to take home, like prioritizing flu vaccine or pertussis vaccine when appropriate. The Pediatric Pandemic Network, this is a national network that was created conceived in 2020 and created in 2021. Now a dozen children's hospitals which work closely with their communities and other hospitals in the area to ensure that hospitals are able to adequately prepare and respond to emergencies from a pediatric lens. And I provide a QR code for that website. Using information from health advisories from the city and the state and the CDC, combining epidemiology, both from our local hospital and from the city and state, and leveraging the educational materials that come out from the Pediatric Pandemic Network. Lurie Children's curates a newsletter roughly every month that provides access to this information and resources from that have a particular relevance for the city of Chicago. And there's an opt-in here if you'd like to receive that newsletter with this key information. I can provide a link in the chat at the end also. Leveraging the EMR is I think one of the most creative things we did. We started this process in 2014. Our ER screens quite a bit for conditions, and we created some logic to screen for travel and symptoms. And so, for example, this is what our screening tool looks like now. We can edit this in real time and add countries if there's something that's active. Like, for example, we added Rwanda recently. So if someone checked Rwanda, meaning they traveled to Rwanda in the last month, and this is taken at intake at the first encounter at our emergency room, and then they selected any of these symptoms that could be consistent with a specific illness, this is what would happen. We'd get a best practice advisory that went to the provider taking this history, letting them know that they screened positive for a possible viral hemorrhagic fever, and then provides some key instructions to get them isolated promptly. And then this patient chart advisory remains in the chart until the disease is ruled out. And this has been effective. We can add this for measles or mpox or really anything. And we have a committee that decides when the risk is high enough to require universal screening for these at our entry points. Once we identify somebody with potentially with one of these infections, it's important that we isolate them promptly. And I tell our team to isolate first, ask questions later. There's never harm in brief periods of isolation. And it's always better to isolate first, ensure that the patient and their family are safe, and ensure that our providers are safe until we can appropriately assess with the appropriate questions and clinical evaluation that was covered extensively in the last talk. This process requires people and personal protective equipment. In our ER, for example, since someone can walk in at any point of any time, every single person in our ER is trained. And then outside of our ER, we have a dedicated team that is responsible for care of children with a high consequence infectious diseases. Here you see them in our level 4 PPE for Ebola or Marburg. It's important that we have dedicated space and supplies. We have space in our emergency room that's designated for care, and we have space in our PICU that can be converted into a 2-bed biocontainment unit that is appropriately marked and supplied to provide safe and effective care to somebody with a highly infectious disease. We also have a dedicated page on our SharePoint that provides really detailed information about how to provide care to somebody with a highly consequence infectious disease, including standard operating procedures. And this is guided by national advisors like NETEC and local advisors from the departments of health. Lastly, once they're isolated, we need to inform the appropriate stakeholders. This can be complex, and you can see this is our notification system. Depending on where they present, from an outside hospital, we get a phone call on the left. In the middle, if somebody just presents to triage from, just walks into our ER, and then the third on the right is if somebody screens positive at O'Hare Airport related to entry screening that we're doing when appropriate. All of these ultimately funnel into our administrative coordinator who runs our command center 24/7, and then that triggers a communication chain that goes to our administrators on call and key stakeholders. Ultimately, the person in my role or who's covering for my role would be responsible for touching base with the Department of Health to ensure that the appropriate clinical and laboratory and public health resources are activated. Most of the time, because we're funneling travel in, the Department of Health typically will know before we do, because it's very unlikely with these high consequence infectious diseases that are just going to present unannounced in our country. Finally, the concept of teletriage. The safest thing is to avoid all contact with somebody with a high consequence infectious diseases, right? But by definition, they need care, but they may not need care at all points of their illness. These illnesses tend to present very mildly, oftentimes almost indistinguishable from other more common and less severe illnesses. And if it gives us an opportunity to be able to evaluate remotely. And so we've developed a virtual immediate. We've had a virtual immediate care program for a long time where families can use telehealth for immediate care. And on our website, we identify those conditions where a virtual immediate care appointment would be appropriate, when an in-person immediate care appointment would be appropriate, and when you require the emergency room. We've expanded this for measles, for example, for the worried well parent whose kid has a rash, but isn't all that sick. And it's better for us to be able to take a history and to view that on a screen and provide some guidance rather than bringing in a patient potentially with measles unannounced into an emergency room where we have infants who are unvaccinated and immunocompromised kids who can get severe measles and die from that. So it's very important that we have those resources in place. Another aspect of teletriage discussed by Dr. Barnes was self-screening and reporting. And so, for example, if we had a healthcare worker who was exposed, our occupational health services would provide instructions for self-screening and completing a daily form by RedCap or Microsoft Forms or something. Others who may have travel or exposures that were identified with entry screening, a similar process would be done through the Illinois Department of Public Health. So that's a brief, high-level overview of how we keep people safe and protect us from the unexpected. And I'm happy to answer any questions.
Great. And I am just going to open up to the CME slides. And again, these will be mailed out. I think there's a question about infection prevention CEUs. We look into that. We're not quite sure what the requirements are. Often the CMEs might be able to qualify. So the basic premise is check with your certifying body and see if they can translate. And if they cannot, then we can look into what additional requirements there are. Again, this is the form. You can either use the QR code or click on the form later. It'll be available for a day or two for those who attended live to be able to get CMEs. Just a note, our next series are actually going to be how you think about how clinicians can think about occupational health exposures. There have been some really interesting series of events that have occurred that I think would be important for clinicians to flag. And then Dr. Leslie is going to lead us into a discussion on One Health, a little bit of which we discussed today. And finally, again, we're going to talk about elder care in the future, as well as some prenatal considerations with the resources. So you can always register there. There's a QR code for the site, and all of this will go out in an email to those registered. And if you have direct questions for anyone on the medical services, medical advisor team, there's also a form you can use to ask a question. So yeah, with that, I will open it up. I'll stop sharing and open it up to questions, or if people want, I know we're past 1 o'clock. If no questions, I'm going to open up the Q&A, then we will end for the day. Let me see. I am not seeing any questions. Does any last call for any questions before we close our session out? Again, apologies for going over, but thank you all for taking the time to attend the session. Appreciate it. All right. Great. Take care, everyone. Bye. And happy holidays.